determinants of health to inform culturally appropriate and sensitive community-based behavioral interventions, drawing on principles of community-based participatory research. He is currently focused on developing lifestyle interventions in partnership with communities to prevent cancer among underrepresented groups. And I am very interested in hearing more. It's all yours.
Thank you. Good morning, everybody.
Good morning. Morning.
Happy Good Friday and Ramadan Mubarak to everybody. Am I missing any others?
Passover.
Passover, yes.
But those folks probably aren't here.
Thank you, Jennifer, for the introduction. Ruby for the invitation to come speak to the school about my research, and Katie, thank you for helping kind of coordinate the logistics, and I apologize for any delays. Standing up here, I'm having a moment of gratitude because back in 2008, I took a course in CBPR, community-based participatory research, with Pamela Ball's Organista, and worked on a study about cultural factors in diabetes management with Chinese immigrants in San Francisco, Chinatown, with Kevin Chun and Kit Chesla. And I remember thinking, I want to do that. I want to teach about that. And I have the privilege and super excited to speak with you all today about some of this research that is really in the early stages of right now. And today, so I'll chat with you about 3 key insights that have shaped kind of my journey in early stage community engaged research. So the first is I've come to realize the importance of having agents of change at every level to truly promote health equity. So it takes a diverse group of people tackling different aspects of modifiable behaviors, outcomes, and biological mechanisms across various socio-ecological levels to really make an impact. While my clinical psychology background led me to focus on more individual level interventions, I've learned through interdisciplinary collaborations that my work is just kind of a small puzzle piece to a larger puzzle and effort to reduce health disparities. I've also discovered that community engaged research has helped me connect with the researchers that generally resonate with communities I'm working with. Even though I'm still in the early stages, it's exciting talking about and bouncing ideas off of community leaders, members, and organizations. And it's really rewarding to really see that they find this research relevant to their own lives and their communities and families. And finally, hopefully by the end of our talk today, that you all appreciate the value of getting more sleep and being physically active. If you can, right, exactly. So first, we'll explore the link between cancer prevention and lifestyle behaviors, focusing on the critical roles of physical activity, sleep, and energy balance. We'll delve into the science behind these factors and how they contribute to reducing cancer risk. Then we'll talk about some community engaged research and the importance in addressing health disparities. I'll start by reviewing the principles and framework of this approach, then examine 3 specific projects that demonstrate how community engagement can help reduce disparities. The first one is Sleepy, which aims to improve sleep health and sleep-related behaviors among African-American adults. Project Shine, a health promotion initiative focused on sleep among African-American adults, and then a community health worker education program among the Somali community. And lastly, we'll explore future directions and opportunities for collaboration, talk about the importance of survivorship, quality of life, and care, and how we can work together to both improve cancer care among survivors and treatment efficacy. And really, I'm excited to share these insights with you, and I'm eager to hear about your thoughts and your ideas of how we can move this forward. So first, I'll talk about cancer prevention and lifestyle behaviors. So cancer continues to be the #2 reason for death in the US. But the good news is that the prevalence rates are on the downward trend, and cancer disparities since the 1990s between Black African-Americans and whites has decreased from 33% to 14%. But the disparity persists, and my research efforts are really to kind of continue to try and further reduce that gap through primary cancer prevention. The cancer in Minnesota, the mortality rate has decreased by nearly 15% in the last 20 years, which is excellent. Minnesota, I saw a ranking recently that it's the 2nd healthiest state in the country in terms of lifestyle behaviors. But 4 out of 5 people out of 10, 4 to 5 people out of 10 will be diagnosed in their lifetime here in Minnesota. And it is the leading cause of death. So when we think about modifying behaviors to prevent cancer, the second leading modifiable risk factor is obesity, which is related to 13 different cancer types. So it's no surprise then that being physically active can actually reduce cancer risk for cancer and reduce cancer-related mortality. So recent studies show that meeting physical activity guidelines of 150 minutes of moderate vigorous physical activity a week can lower cancer risk by 10 to 20%, and maintaining even minimal to some physical activity before a cancer diagnosis, during treatment, and post-treatment can lead to significant decreases in mortality. And even just walking 5 hours a week, on average, almost an hour a day, can reduce cancer mortality risk by 20%. So it's concerning that data in 2018 show that almost 50% of African-American adults, shown in the purple graphs here, report excessive weight, and 55% report not meeting physical activity guidelines. And these rates are in stark contrast to reports from non-Hispanic white counterparts, shown in blue. And shockingly, it's estimated that by the year 2030, underweight, normal weight will be the least common weight category seen in the first tan bar. And it's predicted that severe excessive weight, BMI greater or equal to 35, will be the most common weight category, especially among non-Hispanic Blacks nationally. So why is it, though, that we continue to see these high rates of weight status and low physical inactivity, despite the significant public health discourse, the interventions, and increases in exercise and diet awareness? Well, first, there's a need for more community-based interventions. We know that standard weight loss interventions such as diet and exercise and health coaching is actually less effective among African-American adults. A recent review of standard behavioral weight loss interventions showed that African-Americans tend to lose less weight on average than their white counterparts. And it's also found that when studies actively engage the community, so when community partners are involved in delivering, shaping the intervention, that these effects are actually stronger. So really highlighting the importance of partnering with communities to do these type of lifestyle behavior interventions. The second one is health behaviors don't happen in a vacuum. The illusion of choice and control we have over our own health often masks important environmental factors that can socially determine physical activity. This means that the freedom to engage in individual level behaviors can be limited to various socio-ecological spheres, such as the perceived environment, how we understand the spaces and places we live in, and relationships that we have, the physical environment, the direct physical aspects of where we move about, the policy environment, larger cultural and policy-related norms, values, and rules that govern our behavior do impact our lifestyle behaviors. And the third factor I offer is inadequate sleep. So the energy balance model simplifies to just that. Obesity and excessive weight occurs when there's an imbalance of energy expenditure and energy intake. For example, when the body's moving less, it consumes more. The idea is that weight begins to increase. The dominant approach to solving this equation has really been to have folks move more, right? Or eat less and healthier. That is, increase energy expenditure and decreasing energy intake. Now, recognizing the fact that there's a lot of outside factors, such as in the healthcare setting, can impact excessive weight and cancer disparities like structural racism, neighborhood factors. We've actually spent relatively less time studying and understanding a really active behavior we spend a third of our lives in, which is sleep. Adults are recommended to obtain at least 7 hours of sleep a night, and a third of Americans don't meet these guidelines. And there's significant evidence linking inadequate sleep and energy imbalance, such that those who are chronically sleep deprived, not meeting the sleep guidelines of 7 hours, or 5 or less actually, experience less energy expenditure. So they're less physically active, feel less motivation to exercise, more likely to probably sit on the couch and watch Netflix and stay at home, and experience increases in energy intake through dysregulated appetite hormones, increases in ghrelin, decreases in leptin, excessive eating, and poor food choices, and dysregulated glucose metabolism like insulin resistant. So the importance of sleep has been supported by research and is evident in its correlation to various health outcomes. Data from NHIS reveals that 67% of Americans get the recommended amount of sleep. However, when considering race and disaggregating data, only 59% of African Americans get the recommended hours compared to 69% of their white counterparts. And this really highlights the need to address this sleep disparity. So when I went to MD Anderson, what sparked my interest in this area of linking physical activity and sleep and cancer prevention was the statistic that only 38% of the Project Church cohort of African Americans in Houston were meeting sleep guidelines. So that's severely high as in there's a lot of short sleepers. And so further analysis, I found that there was an association between not getting enough sleep and higher BMI, indirectly mediated through sedentary behavior, meaning folks who weren't sleeping enough were more likely to be sedentary and as a result of higher BMI, which is consistent with past literature. We also then found that there was an association between short sleep and diabetes risk among a cohort of Mexican American adults in Houston. So follow-up hazard models showed that short sleep, less than or equal to 5 hours, at the 3-year follow-up was associated with 4 times increased risk in diabetes among those who were normal or underweight, and 2 times risk in diabetes among those who were not. And the results persisted at the 5-year follow-up, such that baseline short sleep was related to 4 times increase in diabetes risk among those who were within a 25 BMI. So indeed, large epi studies across different samples do show an effect or an association between short sleep and increased risk for breast, prostate, and overall cancers, though the effect tends to be on the smaller end. And so the question is, what might account for this link? So my thought is that it's because of this link between sleep and energy balance factors. So as I mentioned before, the energy balance model suggests that weight gain is a result of an energy imbalance between expenditure and intake. And while much of the focus is on diet and physical activity as they relate to excessive weight and weight gain, there's lots of evidence highlighting the important role of sleep loss and how it can affect physical activity, sedentary behavior, and diet. So for example, observational studies show a bidirectional relationship between sleep and physical activity, where insufficient sleep the night before will predict lower rates of physical activity the next day, and so on and so forth. So colleagues from MD Anderson and I showed this in using Fitbit data. Sleep restriction experiments where they take folks who are sleeping normally and well, and then they restrict their sleep to like 3 or 4 hours, show that when the sleep is reduced, folks tend to be more sedentary the next day. And we also see changes in weight loss and diet patterns when people who are sleep deprived get more sleep. So for example, getting more sleep actually resulted in greater weight loss during a weight loss regimen and lower intake in high caloric foods. So all in all, the data do tell us that sleep plays an important role in the energy balance model, but not only interfering with the daily movement and diet behaviors, but also getting in the way of our attempts to lose or manage our own weight. And this seems like an important idea when there are disproportionate levels of excessive weight and sedentary behavior among certain groups, yet there's really only now becoming a larger area of research. I want to take a moment to highlight a recent clinical trial conducted by Tassali's group that showed that when they did a sleep intervention, they actually showed folks were consuming less by the end of the study. So in the orange bar graphs, this is the control group, and you'll see that the y-axis is change in caloric intake, that folks, actually tend to eat more over time. And then in the green or dark green bar graphs, those are folks in the intervention trial, in the sleep intervention. And the third graph will show, there's this association between the change in sleep duration. So as folks tended to get more sleep, they also tended to consume less. So with these in mind, in the research I was conducting in Houston, I was convinced that action was necessary, or at least tried to take action, given that folks were generally focused on exercise, diet, and screening behaviors. Coming back to today's theme of the talk, I'll move into discussion about how my experiences started from kind of coming up with this data, coming with these results, and then moving towards more action-oriented intervention work. And so I'll talk a little bit about some of the early stages of the work I'm doing now. I started in Houston. So after identifying the shockingly low rate of sleep among African-American adults in the church cohort in Houston, I drew on my clinical experience as a clinical psychologist in treating sleep disorders to set out to answer the question, is the community interested in addressing their sleep? And if so, can we improve sleep to help folks become more physically active in the context of cancer prevention? Paulo Freire, Brazilian educationist, critical theorist, and grandfather of CBPR, had this idea that transformation in communities could only happen through praxis, which is knowledge generated by the community going hand in hand with. In practice, this means placing the community and researcher in the middle of the research process, mutually informing the research questions that are asked, how the research is designed, how participants are recruited, and how information is disseminated. So guiding my efforts, I draw heavily on principles of CBPR, a type of community engaged research that has high involvement in the community throughout the research process. And so briefly, here are the principles. The first is the community is a unit of identity, meaning that the community being worked with and partnered with is viewed as a distinct identity with its own culture, history, and values. So CBPR builds on the strengths and resources within the community. Researchers work with partners to identify what are existing strengths and build upon that within the community. So it's also a collaborative and equitable partnership involving power sharing equal power sharing to address social inequities. So this principle really emphasizes the importance of power sharing between both of the partners. So for example, this might take the form of academic partners leveraging institutional resources or skills or infrastructure and structure to achieve and help build capacity for research within a community-based organization or within a community. Or on the other hand, the community organization power sharing its resources to the academic partner, giving access to those pieces. There's also co-learning and capacity building among all partners. So CBPR emphasizes that learning occurs between community members and researchers rather than just researchers from the community. And achieves a balance between knowledge generation and intervention for mutual benefit. So this principle really emphasizes the importance of generating knowledge, not for knowledge's sake, like writing a paper, but also knowledge that benefits the community as well. Also focuses on local relevance of public health problems and ecological perspectives, such that researchers really have to consider what the local context is and what are the local ecological factors that are maybe unique to this environment that influence these. Involves systems development using cyclical and iterative processes, meaning both capacity building, knowledge generation. There's structure to how this happens between both the academic and the community partner. And dissemination results, dissemination happens, or dissemination is given to all partners and involves them throughout all the processes of dissemination. And researchers must share their findings with community partners and involve them throughout the whole process, basically. And this is a key piece, is the long-term process and commitment to sustainability. And this is particularly important because, especially for academic partners whose efforts may be tied to funding, there's a commitment when entering the relationship that despite some of these limitations, even if there is none, that the research continues, or at least the research is given away to the community such that when or if the academic partner is not present, the research and the interventions can continue. And so with these principles in mind, I'll briefly present Nina Wallerstein's model of CBPR. I'm not going to go too in depth, but I'll go through highlight kind of key aspects of it. And I think this is important just to give a framework for all the moving parts and how this works. So in the first box, there's context. So this represents the community and its environment. So CBPR is grounded in the local context and ecological factors that impact. And this includes honoring the culture, history, and values of the community in the partnership, which then can influence the partnership process. And this represents the collaborative nature of CBPR. So it involves building equitable partnerships with community members, researchers, and other stakeholders. And I think really this is the aspect that makes CBPR and other types of action participatory types of methods unique to traditional methods, is that it explicitly outlines the importance of the relationship. And that is the centerpiece of all the work. The third box is, and those two then inform the intervention and research development, and this highlights the processes and resulting outputs for each. So for example, integrating community knowledge in the intervention and research can result in cultural centered interventions, and involving community in the research can yield appropriate methods and approaches. And lastly, the fourth box, so outcomes. So this represents the impact of CBPR. Outcomes aren't just for academic publications. It'd be great to get a JAMA paper or New England Journal of Medicine paper, but unlikely. But also, this is more about the impact on the community. So CBPR is about achieving positive health outcomes, building community capacity, and achieving equity health as a long-term goal. So using Wallerstein's framework and building upon principles of CBPR, and that's kind of my guide and my compass for how I approach this work. I use a model by Barrera that guide the development of culturally appropriate behavioral interventions. And this is an iterative process, and there's multiple steps. But the first is gathering information and designing the intervention. It could include identifying the need, obtaining qualitative and quantitative evidence that points to a need, and getting community feedback on study materials. Second one is conducting preliminary adaptation tests, such as pilot studies, while also soliciting feedback from participants. The third is using feedback to revise the intervention. Again, this is an iterative process, so you can go back and forth quite often. Going back to community folks, getting feedback on what went well, what didn't go well, what needs to be changed. And lastly, a larger cultural adaptation trial, taking everything that's learned and shaping the intervention. So given that background, I'll go into 3 ongoing efforts that draw on CBPR principles related to cancer health disparities. The first is the SLEEPY trial. This was developed when I was a postdoc at MD Anderson and was kind of the brainchild of the earlier studies I was talking about, linking physical activity and sleep in the context of cancer risk. The second is Project SHINE, Sleep Health Initiative for Equity. This is the extension of SLEEPY and funded through MHC as a kangaroo. And the third one is the third project. The third project is a little different, but highlights the promise of building capacity among community health workers to promote health among the small community. So first, I'll talk about SLEEPY. So SLEEPY is an ongoing trial right now, has the overarching goal of increasing physical activity and sleep among African-American adults who are sleep deprived, who don't have overweight or obesity and are sedentary. The main aims are to better understand the experience of sleep and receive feedback on intervention materials, test the feasibility and satisfaction of a 9-week sleep and physical activity intervention. And while we weren't powered to test intervention effects, secondary aims were to examine the preliminary efficacy and sequential effect of the sleep and physical activity intervention. This was a mixed methods pilot study, so qualitative and quantitative. The first step in the intervention design was gathering information and developing the preliminary design. So we developed the sleep and physical activity intervention materials, decided on instruments for measurement, focus group the protocol. The sleep intervention itself uses components of CBT. I'm happy to go into more detail about the intervention itself if folks are interested, but I'll kind of move on. Essentially, all of this was brought to the MD Anderson Center for Community Engaged Translational Research, the Community Scientist Program. So this is where folks from the community are trained on the research methods, trained on how to provide feedback to researchers interested in doing this type of work. And so it's very structured, and folks are also compensated for their time. And so intervention materials were presented to them, and that's the way I initially got feedback. So the second step after receiving the feedback was integrating feedback into the study, and then collecting and then conducting the preliminary adaptation test. We designed a 3-armed randomized crossover trial that included a physical activity intervention and a sleep intervention. Again, if you want more details about the design, happy to talk more about it. But the general idea is to improve physical activity and sleep by way of coaching, working with individual coach, delivering a sleep intervention and a physical activity intervention. So some prelim data, demographics, folks were on average 49 years old, more females than males. Average BMI was almost 36. And what we expected was most didn't meet physical activity or sleep guidelines. That was one of the inclusion or exclusion criteria. MVP, moderate vigorous physical activity per week, was half an hour. Sleep, on average, folks are getting less than 6 hours a night and sitting more than 8 hours a day. And actually, 8 hours a day, that's almost the cutoff for some research suggesting it's related to worse outcome. So far, we have 16 folks who have completed it. Generally, folks are happy. Those who went through the intervention, they liked it. Conducting the intervention, what I learned is individuals, one, talking about sleep didn't happen often in their life. So it was novel. Thinking about their sleep, trying to change their sleep in a very structured way for 4 weeks was a big change for them. And so they really liked that. That was actually really engaging. I asked folks to to track their sleep every day for a month, for 4 weeks. They'd have to fill out what time they woke up, what time they went to bed, their quality of sleep every morning. Imagine doing that for 30 days. Most did it, surprisingly. I thought folks weren't going to, but they did. And I think a lot of that was, one, they wanted to improve their sleep, but also, having someone work with them intensely for a month helped a lot. Because most of the intervention trials are sleep hygiene trials, where folks are just given information about here's how you sleep more, and then they move on. Doesn't tend to work. The next one I'll talk about is Project Shine, the Sleep Health Initiative for Equity. So while currently conducting Sleepy as a preliminary test of the sleep intervention, I'm also conducting research that will help refine the intervention in the R00 phase. I outlined 3 different aims that seek to answer the question, so what are the experiences of sleep here in Minneapolis among African-American, Black African-American adults? And what is the preliminary efficacy of the sleep intervention? So next I'll go into some of the qualitative findings around sleep from folks in Houston. I'm looking at the time, move a little quicker. So in Houston, we conducted 10 qualitative interviews, used a thematic analysis, and came up with, found 3 main themes. The first was sociocultural factors related to race, gender, and family. The second was church, faith, and religiosity barriers and facilitators. And the third was beliefs and behaviors around control of sleep and sleep practices. So sociocultural factors that were related to race. One participant said, I think people of color in general can be a bit more stressed. I'm coming off the top of my mind, we can be a little bit more stressed than other cultures. I like to think that something must have been passed down through the DNA. I think she was referring to historical trauma. Another one said just societal stress, cultural stress. I consider myself to be middle class, but I still stress like race in America. I'm dealing with prejudices, worrying about how it impacts my family, my children, their future. And so when I get on Facebook to decompress, veg out, whatever, it's more of, oh, there's another police shooting of an unarmed person, or there are more African Americans who are dying from COVID, or all these Caucasian people with assault rifles, at the state capitol. Black folks couldn't do that, like you'd have to have a toy gun or no gun to get shot. So really highlighting societal stressors around race really impacting sleep. Gender and family is also large. Remember, most interviewed were female, or were women. So I think it's different for women, regardless of your ethnicity, because women have all the workplace career stressors, but also have the stress of what's for dinner, are they eating healthy, grocery shopping, education for the children, general welfare, emotional stability for the children. Like we have all these additional stressors. My husband doesn't know. Another one said, I think we're nurturers. We're going to do all the checking, ticking of boxes. And then another one had said, this particular woman, the last one, has 3 children, and I think was a single mother. And so there's a lot going on with that. The next theme was church, faith, and religiosity. We also found that spirituality and faith and the church did help folks get sleep and we're getting enough. God helps me with sleep tremendously. If I have a problem and I can't sleep, I said, God is able, and that's it. Then I go back to sleep because I say I trust him. If I could do something about it, I would have done already. Another said, if I wake up and something's really on my mind or something I'm concerned about, I just read scripture. And last one said, faith is what got me to the point where I can sleep and sleep peacefully. On the other hand, the church structure itself sometimes got in the way of folks getting sleep. The other side, when I want to get on the prayer line, but like it's 6 o'clock in the morning, I'll keep waking up every hour thinking I've overslept. So this person was very, very conscious about what time the call had started in the morning. She was really, didn't want to miss it. The last piece is becoming overwhelmed. Oh, we just have a lot of community activities, church activities. And this is pre-COVID, by the way, I should say. So folks were really involved in the church and doing these church activities. Once COVID hit, things changed significantly. The last theme is sleep is seen as controllable, and there's some effects of the sleep hygiene practices. I could go to bed at a regular time and wake up at a regular time, but I still have the mindset that of when I'm done with the work, I deserve to do something that I want to do, something on my to-do list, or something that brings me joy, or I just want to do it. Fortunately, though, a lot of times that just cuts into my sleep time. So it's almost like the sleep time is this buffer time. It's like this slack time that can be used, that ends up being used up for leisure activities or work. Like when I go get ready to go to sleep, it's like my mind is going constantly about what I need to do, what I've done, what's going to happen, stuff like that. I tend to let my mind roam. So really here, what you're getting a sense of is stress, right? Coping with stress. Sleep actually ends up being, giving up sleep ends up being a way of coping with it. But then there's a cyclical process between not getting enough sleep and experiencing stress. And it's really funny because when you look at the list of what sleep hygiene factors are, it's managing stress. So not going to bed stressed out. So we have to think about, how these sleep hygiene guidelines and practices are they appropriate? So based on these themes and combining with a new set of interviews, I'm hoping to conduct here in Minneapolis. Right now, still trying to identify a community partner to work with. Reached out to a number of folks. Makeda over at URock has been very helpful in reaching out. Rhonda has also been very helpful. They've been reaching out to different. Paul Robinson has also been very helpful. And so slowly we're coming to develop a partnership and a relationship where we can start doing some of this work. But so far, based on what we have, I'll be engaged in some intervention adaptation methods. And so there's two types of adaptations you can think about: surface level and deep level. So surface level adaptations are things like changing how the flyer looks, how you recruit. More deeper level strategies are there constructs and concepts you can integrate within the intervention that will facilitate and make it more relevant. And within that, there's you can further delineate surface and deep level adaptations to peripheral strategies. These are surface level ones, like changing the color, images, fonts, linguistic strategies, changing the language to improve comprehension, constituent involving strategies. So using the cultural knowledge and experience of the group to make it more relevant. Sociocultural strategies, recognizing, reinforcing, and building on cultural beliefs. So really using what we know to situate the intervention on existing values. And evidential strategies, using evidence such as epidata and experiences from individuals with similar backgrounds to increase the relevance of the information. So bringing in, oh, well, maybe, some of the stress you're experiencing isn't all your fault, right? There may be structural issues going on here, and that may help to externalize some of these issues. And so I hope that, as I begin developing these relationships with community partners, that we can have these conversations around how best to make these adaptations and intervention. And here's the final design of the intervention, or the RCT, 2-arm randomized control trial, individual sessions with folks once a week. 2 conditions, sleep, and then there's again, I can talk more about design if you like. So the last part, I want to talk about newly formed community partnership with Metro Youth Diversion Center. The idea of the study came about with a close friend in college from graduate school, and I were sitting around with this community-based organization at a coffee shop. We were talking about research ideas, future directions of his organization, historical experiences of researchers coming into the community. What has that been like? Kind of my research and around cancer prevention. At some point, the question was asked, hey, Ivan, we have a community health worker. Do you have resources on cancer prevention and control to train him on? Because they were talking about these different thoughts of cancer and barriers to cancer around, cultural thoughts around cancer that get in the way of folks getting screened. And so I looked around and I tried to find something. I couldn't. And I said, hey, why don't we just make our own? That's culturally tailored for the Somali community. So yeah, let's do it. So we wrote up a grant, and then MCC, it was awarded by the MCC Community Catchment Pilot Award. Very grateful. Thank you. Yeah, super excited to do this work. The ultimate goal is to do a qualitative needs assessment to develop a cancer prevention workshop to improve capacity for community health workers working within the Somali community to disseminate knowledge and increase screening and lifestyle behaviors. So I was really hoping one of my community partners could come join and give a little piece of this. Scheduling kind of got in the way. But I'll talk a little bit about the community here. It's important to note that, again, cancer is the second leading cause of death among African Americans nationally. And within this population, there's limited research on immigrant and refugee groups, particularly the Somali population in Minneapolis. And there's folks here doing that type of work. So existing studies have shown that there are disparities in the cancer screening rates among the Somali community. There's higher levels of unhealthy weight status and lower engagement in physical activity. And there are a number of barriers to screening that have been identified by folks such as Rebecca Pratt or Michelle Allen in the Cancer Center doing this work. Cultural differences, limited knowledge about cancer screening, general lack of trust in the healthcare system, and religious beliefs that may influence health-seeking behavior. These are all factors that we're hoping to better understand through the qualitative interviews, and then hope to address in the community health worker workshop. The project involves a partnership between Metro Youth Diversion Center, or MYDC, and Abdel Fattah Ali and myself. This collaboration was formed based on shared goals and a commitment to improving the health of the Somali community in Minneapolis. Each partner plays a crucial role in the project. So MYDC focuses on more the community engagement piece of it, and academic partners, myself and Abdi, focus on the content, research design, workshop development. And we all come together when we meet and share ideas, and it's really mutually informative. The main 3 aims are to conduct qualitative focus groups to investigate cancer-related attitudes, knowledge, beliefs, and help-seeking behavior among Somali adults. And the aim 2 is to conduct individual in-depth interviews with health workers, community health workers, to understand their cancer-related attitudes, knowledges, and beliefs. And then take those 2 figure out the gaps, learn what needs to be addressed, and then develop a workshop that increases the capacity for our community health workers to go into the community and address some of these gaps. So research is grounded in the theory of planned behavior, which you can see in the second ring. So in the center is cancer screening and lifestyle behaviors. The next ring are aspects of theory of planned behavior that we want to better understand. And then the more outward ring are community health workers and the community members, so their perceptions of it. And the main thrust of the study leverages existing models of that use community health workers as mechanisms to disseminate cancer prevention knowledge. The model is based on the Promotoras model, which is a community-based health education and outreach model that employs trained community members or promotoras to provide health education and support underserved and minoritized communities. Ultimately, through these qualitative interviews and focus groups, hopefully we have at the end a culturally tailored and culturally appropriate workshop for community health workers. So we unofficially started meeting back in November. So I joined in October. Got to meet the organization in November, and then we wrote something up and ended up getting funded in February. So, the grant is, symbolically for us was very important because it formalized the partnership and gave us an opportunity to kind of leverage each of our resources to do this work. So right now we're developing the protocol, trying to figure out how the finances run, how the finances work, how funding is transferred from one institution to the other, talking about how to form the CAB, so the Community Advisory Board, who will serve on it, the role of each person. And the CAB is actually very vital to our research because they'll end up being the sounding board for how best to interpret the findings and do this work. And so as I continue to make really gradual process on this work, putting together this talk has forced me to kind of reflect on my early experiences. And so I'd like to share some of my thoughts. And I also want to invite others who are doing this work or plan or want to do this work to share your thoughts too of the community engaged research. So the first is, I'm just amazed by the work these community-based organizations are doing with the level of funding they receive. NYDC was recently invited to the White House for dinner based on their violence prevention work. And their commitment to violence prevention and substance use education among the youth has been so inspirational. I saw 4 or 5 years ago when they started, I was in conversation with them about, this is what we want to do. And now they're doing it, which is amazing. And so I feel privileged to partner with them and really witness their dedication to the community firsthand. Research infrastructure isn't always present. And there's a reason for that, as CBOs, community-based organizations, are often focused on direct impact on the community. So then that means taking funds and resources to make change. That doesn't always mean there's infrastructure to collect data, analyze data, but then that also opens an opportunity for research academic partners to partner together to address some of these issues to help build and guide research infrastructure development, especially around securing additional funding. Third is community engaged research exists on a spectrum. Achieving true CBPR is challenging. There are a lot of factors that go into doing true CBPR, which is why I say my work is informed by CBPR principles. One key aspect that I found most important is the relationship between the partners. With that, I think things flow much easier. I've known Abdel Fattah since graduate school, and Rashad, I've gotten to know him very closely, and our mutual understanding around this work and our collaboration helps a lot. For example, we're talking about including Oromo participants in the study, right? This is a group that's considered within the Somali community, but culturally distinct. But then we had to talk about what that means. We'll need a different, logistically, we'll need a different set of facilitators, right? That'll cut our sample size in half. What does that mean for data quality, as well as impact? But the conversation was very, very transparent and free-flowing because we were all on the same page already. Fourth, I've learned that being flexible, transparent, and open about my needs as an academic partner helps community members understand where I'm coming from, what my intentions are, what my agenda is, and what my limitations are too. Sometimes relationship is more important than science. Community-based research often requires us to adapt our pace and direction to maintain sustainable partnership, even if it doesn't align with our academic timelines. For example, my current grant, the Project Shine, I budgeted 6 months just to develop relationships with a partner, and it's going slowly. I'll probably need a couple more months to really have that fleshed out. So really kind of understanding that we may want to move at one pace, but then the relationship and the method may take a different timeline. And the last piece is the patience is essential. So building trust in community engaged research can take a lot of time, especially given the historical, the history of researchers within these types of communities. What I hear a lot is there's a lot of research fatigue. So folks coming in wanting to know, oh, what are your thoughts? Right? They hear that quite a bit. And so really nurturing the relationships with community leaders helps make the research much more impactful, meaningful, and sustainable. And so based on this work, with the little time I have left, 2 directions I want to move forward on. One is improving survivorship, health behaviors, and care in the community. You know, this is a busy slide. Essentially, we know, right now I'm working on a paper that characterizes health behaviors in cancer survivors. And we see that in general, those with a history of cancer in the dotted lines are less likely to meet physical activity in the green line and sleep in the blue line guidelines. So it's not surprising that because of the challenges of care, its treatment, and long-term effects, it really highlights the need for more supportive care around this area. So if you kind of check out with the non-Hispanic Black, if you look at those with cancer who are meeting sleep guidelines, that's very low. And so, Dr. Sue Everson-Rose, Rhonda Jones, and David Haynes and I have begun talking about and working out some directions to address this issue. Second piece is better understanding the mechanistic pathways. So if we see changes in health behavior, do we also see biological outcomes? I see the implications of this research being used to support behavioral interventions, to support behavioral intervention around cancer treatment outcomes, cancer survivorship care, to reduce, to improve things like efficacy, reduce mortality, and manage cancer progression and metastasis. So I've started some early formative discussions with folks in the Cancer Center addressing some of these issues. But I'd love to hear your thoughts, opinions, and efforts around both of these areas moving forward. I want to thank all my mentors, collaborators at MD Anderson and University of Minnesota who've helped support this research or are also helping shape the vision of this research. My community partners, Metro Youth Diversion Center, and at UROC, at Funding Sources, CPRIT, NIH, and the Messiah Cancer Center. So thanks so much. Thanks, I'll take questions.
Thank you for your talk. I was curious, you talked a lot about stressors, right? Stress and activity, as well as sleep deprivation. How are you planning to measure or in general, just like kind of characterize that so you can kind of implement obviously.
Yeah, for sure. So there's the qualitative interviews that we make space to delve into the stressors. Then there's the self-report questionnaires. So I didn't really get into the methods, but there's a self-report questionnaire of stress that we'll use in the intervention design. I think the daily diaries, because when folks are doing the intervention, they also rate their stress the day before. And then some work I'm hoping to do is around the inflammatory biomarkers, so stress as a pathway.
Thank you very much for this. So in terms of this EPR, was in the correct? Okay. So it's a very long process, right? And so my question is, so because it's a long process, do you think the pilot part, you've done the pilot part in Texas, and now you want to apply it, like use it and apply it to Minnesota? How usable that information will be? Like how much that information do you have to do the pilot? Because you said so like going back.
Right. Yeah, that's a really good question. I'll also say I'm still learning CBPR. So, these are some of the lessons I've learned through experience and through thinking and talking with CBPR scholars. So I'm, open to hearing how other folks approach it and whatnot. That's a really good question. And that was actually something we've talked about. The pilot study in MD Anderson, because then the question is generalizability, right? Can you generalize the group in Houston to the group in Minneapolis? I try to not. That's why I'm redoing these qualitative interviews. So the first phase of the K99. So within the K99 phase is a 2-year research phase where there were the qualitative interviews in Houston. So I'll be doing that again in the R00 phase. That was not initially in the grant proposal. But my thought was, well, I'm coming to a new space and this will give me an opportunity to learn and get to know the experiences of community members. And so that was really important for me. So yes, I think, yes, it's usable in that it gives me a structure and experience of like how to do it. But then again, I'll have to have conversations with my community partners about, all right, so here's what we found in Houston. Like, what do y'all think? Do you think it's going to replicate? Is it similar? Is it not similar? So yeah, I think that'll be a good conversation to have with my community partners. Good question.
It's gonna blow up your timeline. And I can't believe the reviewers didn't care for your K99.
Yeah, well, it's fed through MHD, so I think I reached out to my PO and said, hey, I'm going to a new space, right? Like, would you be okay, or what are your thoughts on me redoing some of these qualitative interviews? And say, yeah, of course, that makes sense. It makes total sense. I think in the spirit of the effort and work, they were okay with it. But you're right, it does kind of blow up the timeline.
Yeah,
It
you
totally
get to do that at your trial. Yeah.
Mhm.
So why was, the NHANES data said sleep was going to be some prevalence, and then that church cohort had really low, like what was the explainer for that? And are you expecting something similar here?
Yeah, it's tough to say because in aggregate, you're going to lose specific subpopulation, experiences. And the question of why Houston was so low,
Yeah.
I don't have a good answer for that. I could try and make something up, but
Was it assessed in exactly the same?
Sorry?
Was it assessed in the same way, same measure?
The
Person?
No, it's the same. It's the same.
Maybe it was the age.
That's possibly. That's possibly. Put my thought into that. Yeah.
I'm curious what it be here.
Because I feel like in more community, so I've been a part of my master's. I worked for somebody who was doing something similar, not sleep. They weren't looking at sleep. They were looking at a physical activity and a nutrition intervention. They recruited their participants through a church, and it's still going on, like the after effects of it. But
Right.
is what it was. But anyways, and during that, I felt like the women that we were talking to, like, were way more open to talking about or admitting maybe that they were like maybe lower in sleep, I guess, or something like that. But they were very like upfront, like, no, we don't use that in the food that I make, or things of that nature. So I feel like maybe just having a smaller community could have been. I'm not sure, but
Could be right. Could be a measurement thing, right?
Speaking as someone with a sleep disorder, time of year is huge for me, and it's going to be huge in Minneapolis, and it may be different from Texas. I'm somebody just strap of light, I'm up. So it's like, if you interviewed me in summer or you interviewed me in winter, you'd get quite different results.
Yeah.
I suspect.
Yeah, we definitely thought about that too. A big piece of this too. I mean, with anybody who's doing lifestyle interventions, holidays, right? There's a lot of seasonal effects that we have to consider. But here in Minneapolis, it'll be interesting to see what we end up doing.
in your Shine project, are you planning on doing like a delayed intervention with the people that you had their intervention and then you had a control group?
Mm-hmm.
Are you planning on like switching that, considering that
Crossover.
that sleep, intervention is effective for people in their health?
Yeah, thought about it.
Like,
You're saying like a crossover, right?
I don't quite understand. I mean, why is the randomized trial?
what, maybe I didn't.
I mean, it's a randomized trial, right?
Yeah. Was your question, since folks aren't getting the intervention, opportunities to get the intervention later? Is that
Oh,
Yeah, sorry, that was
Yeah.
my question. Because like a delayed intervention.
right?
Like that happens.
Yeah.
So that they can all benefit. There's actually.
Yeah. When we wrote up the design, we considered a lot of, that was one we did consider. And it's always balancing the design and then impact, and then what do you do with that data? And it's likely we may also change it too, because you're probably right. And one experience we had in Houston was folks who didn't get if you're randomized into an arm that you get nothing. Oh, it's folks they're not the most thrilled about it, right? In the sleeping intervention, there was 3 arms, right? Sleep, physical activity, sleep, and then there's an educational control. Folks in the educational control generally were okay with it. There was 1 or 2 who were like, hey, I was really hoping I'd get the intervention. But I think there was also an understanding of this is just how the trials work, right? And there's no promise that if you get this intervention, you're going to be sleeping more or you're going to be more physically active, right? So I think one assumption of this delayed effect, right? What you're talking about that design is that you're going to get an intervention that's helpful, right?
Yeah.
We don't know that yet. So if it was, then yeah.
They would have the resources.
Yeah, so we do. Yeah, we give materials and all that stuff.
In your future actions or what you're doing right now, the improved survivorship, are you looking at adults or are you looking at kids?
Adults, man.
Adults.
Yeah.
Okay, so adult survivors. I just.
I know more about adults than kids, but I won't rule out collaborating with folks around kids. And diet, that's actually diet nutrition. That's one piece that I didn't really talk about in the talk, you'll notice, and there's a reason for that.
What if their cancer therapy's been out there providing an IV?
Yeah.
I have someone I know who needs a survivor.
Okay.
If you want to, let me know.
Well, it's 11 o'clock, so I think we'll wrap up. Thank you very much for a really wonderful talk. It's great to hear about the complexities and the ways that community partnerships grow and develop. So thank you, and thanks everyone for coming today.
Thanks so much for coming.